Uh, yes, hello. अरे Hello.
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 Yeah, can you hear me?
Yeah, I can. Can you hear me?
Yeah.
Yeah.
Manasi is there, huh? She.
Yes, sir. Yes, I can hear you. I can hear.
Okay.
Is Gagan online? Nirmal has joined. Now I can see everyone. Hi, Rahul.
Hello. Yes. So which project it is? Can you contact Dr. Baby Lakshmi? Because actually they only submit. You know Baby Lakshmi? I'll just give you the number. 1 second. 948 18 11 694. One more number is there. 888 463 3798. 1 minute. Sorry. This is genetic architecture. This is the one which is the Jiva's project. You can contact Monojit Devnath. You know, Monojit Devnath is in the genetics lab. I'll just give you the number 1 minute. Or you can contact Dr. Nitish Kamble. You know Nitish Kamble, 431. Start 431. Sorry, not started. Okay.
Hi, Nirmal. How are you doing? Your mic is on mute. Nirmal.
Now, can you hear me?
Pramod, your mic too.
It is getting muted.
Yeah. I think they have the setting there.
Okay. So it's not good now. Can you hear me now?
We are seeing two
Nirmal
pinacles.
bhaiya, kaise ho?
Yeah.
How are you, Nirmal bhai?
I'm good with the step.
Voice isn't loud enough.
Okay, I'll just.
Meenakshi, we are seeing two photos of yours. It's very difficult to concentrate which one we should. One is 20 years younger.
The one which is active. The other one is the background. Hi, Gagan.
Gagan is there?
Yeah, Gagan is there.
Oh, right.
So I can always post like I'm seriously attending. I can put up that and go. So how is Maharashtra? Gagan, you are muted.
Okay. Right. Is Rahul there?
Yeah.
I can't see. Right.
Yeah, is Rahul ready?
Sir, Rahul sir was there 2 minutes ago. I think he will come back.
It's almost time.
Yeah. So, should we begin in a minute or so, right? It's
Sure,
12
but
o'clock.
Rahul should be ready.
Yeah.
Rahul should be ready.
Yeah. Should I give him a call and see?
Yeah, Rahul is ready now. Rahul is online. Hi, Rahul. Hi, Rahul. Rahul, he's just connecting to audio.
Okay. Okay.
He's there.
So should I stop sharing my screen? Then we can start the meeting.
Pramod, you've got some
Rahul,
slides?
No, I don't have slides.
Rahul, your
I'll just-
background is too bright. We can't see your face. Rahul. Bhavesh, why don't you call Rahul and tell him?
Oh yes, I'll call him up and I'll tell him.
Please do, please do. His background is too bright.
Yes, I'll tell him.
Do you have any idea how many have joined? Is there any as of now?
I think Bhavesh can see that. I can even we can see. 166 have joined.
Oh.
166.
Well, that's
Great.
a good
168
number
now.
to begin with, I think.
Yeah, I
Right.
think we should start.
Yeah,
we should start on time.
Yeah, let's start.
Sir, so I'll stop sharing. Who of you all is going to share the screen?
So I'll speak for a couple of minutes, then President Dr. Pramod Pal will speak, and then it would be Rahul, and then Nitin. Is Nitin on the line? Nitin Sethi?
He is there, but not yet joined the meeting completely.
So, right. Should I call him up? Yeah, I'll just call him up and so friends, colleagues.
I think he's joined.
He has. Right. Okay. Friends, Mansi, is it?
Yes, sir.
So am I speaking?
Yes, you are audible, sir.
Right. Okay. So friends and colleagues, this is, we are going through unprecedented times. It's an unprecedented moment. At the same time, I think we have challenges, and challenges present new opportunities. We never had a web-based online teaching program in the IEN, and so I think we have basically converted a huge challenge into an opportunity. Let's take it further. This is the first and the inaugural webinar of the Indian Academy of Neurology. I request the president of the Indian Academy of Neurology, Pramod Pal, professor of and neurology department, NIMHANS, to set the ball rolling. In a way, he's inaugurating this series of webinars of the Indian Academy of Neurology. 3 cheers. I request Dr. Pramod Pal to give us the directions and also to inaugurate the webinars series of the Indian Academy of Neurology. Pramod, please.
Thank you, Dr. Gagandeep, and good afternoon all, dear esteemed members of the Indian Academy of Neurology and all others who have joined this webinar, as well as respected chairpersons. It is indeed a very unusual situation today where the whole world is struggling to survive. Already globally, more than 1 million people have been affected with COVID and almost 53,000 deaths are there. And India is still struggling with an exponential increase in the number, and almost 2,500 has been affected so far. In the last 3 months, we as humans, as well as physicians, have learned a lot of lessons and still are totally unaware what the future would be like. COVID-19 has surpassed all boundaries, and now we have twofold tasks ahead: to serve the community as physicians and to maintain the integrity of the neurology specialization and the Indian Academy of Neurology. We have to keep ourselves abreast of all the aspects of COVID-19, serve the community as per the government regulations, and also see how best we can practice neurology. It is not COVID-19 that spares the nervous system, and in the coming days, we will become more wiser as new epidemiological data surface. IN proposes, as Dr. Gagandeep has already informed, to start web-based programs in a regular fashion to constantly update the knowledge of our fraternity, as well as engage in active discussions. And today I open this webinar for the Indian Academy of Neurology and also for the people of India. And we have 2 eminent speakers who will discuss about COVID. In the days to come, we plan to conduct webinars on current issues. Though casualty and emergency services are accessible to all patients with acute neurological disorders, the hardship will be most for those who have chronic and subacute neurological disorders and do not have priority to attend the casualty in these hard times. There will be also issues of drug availability. IN has already prepared guidelines on how to take care of patients with demyelinating disorders, especially who are on immunomodulation or experiencing relapses and cannot attend the hospitals at a priority basis. Other subsections like neuro rehab and movement disorders will soon come up with appropriate guidelines to help their patients. And I also request all other subsections, as well as more specifically the clinical neurophysiology subsection, to come out with guidelines at the earliest to see how best we can serve the patients who need electrophysical evaluation, but at the same time to prevent social distancing and how best we can do electrophysiology. So finally, COVID pandemic has put our society under an incredible health, emotional, and economic burden. We should join hands to serve our community in whatever way we can as physicians, neurologists, and good Samaritans. We will interact closely with Ministry of Health and Family Welfare and also the Indian Council of Medical Research and provide all the expertise and support from our society. Finally, please do take care of yourself, your family, and stay safe. Thank you very much.
Thank you. Thank you. Mansi, can you put it back to me? So much, Dr. Pramod Pal. Can you hear me?
Yes.
Yes.
Yes,
right.
yes.
Excellent. Right. So we go on with the proceedings of the webinar. I would request the eminent chairpersons today, Dr. Nirmal Surya and Dr. U. Meenakshi Sundaram. Dr. Nirmal Surya, as you know, is the treasurer of the Indian Academy of Neurology. He's from Mumbai. And Dr. Meenakshi Sundaram, everyone knows, is from Chennai. He is also a member of the executive committee of the Indian Academy of Neurology. So I would request both the chairpersons to take over from this point onwards, and I would request them to introduce the speakers and to conduct the session, including the questions and answers. We've already started getting questions. Meenakshi and Nirmal, we have already started getting questions. So over to both of you. All the best.
Nirmal, go ahead.
So is there a presentation you want to show?
No, both of them are not having presentations, I think
No,
so.
no. Nirmal will just talk. Yeah. Nirmal, we can't hear you. We can't hear you, Nirmal.
Meenakshi, can you take over and then Nirmal can set his
So
things right?
may I have the pleasure of inviting Dr. Rahul Kulkarni. Rahul is pretty well known for his academics. Rahul is from Pune. Can you hear me?
Yes, we can hear you now.
Yeah. May I request Dr. Rahul Kulkarni to please make his presentation? Dr. Rahul Kulkarni is a very well-known academician from Pune, a good friend. Rahul, please, good morning, and please take over.
Good afternoon. So Bhavesh, can I have my slide sharing? Bhavesh, you need to remove your slides so that I can share my slides.
Yes, I'll just do that. Yes, now you can start sharing your slides, sir.
All right. Okay, can you hear me?
Yeah.
Yeah. So good afternoon, everyone. Today I'll be talking about COVID-19 and the neurological care that one has to take. First 5 to 7 minutes, I'll be talking about the disease per se, and then maybe we'll go towards the neurology of the disease. We all know that the disease has started about 4 months ago in December 19, when in Wuhan we had the first cases which were reported. Remember that the cases came when they had exposure to the seafood market, which traded these live animals, and rapidly it has spread over the year, all over the world. First case was notified by China on 31st of December. Within 7 days, the virus was identified as a coronavirus, which had more than 70% similarity to the SARS coronavirus. First death was reported within first 10 days. 20th of January, the first case was reported in the healthcare worker. First case in India was reported on 30th of January. And by 11th of March, WHO said that this is a global pandemic which has been happening all over the world. So the disease has rather rapidly spread all over the globe. And we know now that more than 200 countries have been affected. In India, probably it has become a disease which has affected all over the country, though certain states like Maharashtra or Kerala have been the predominant affection. And the cases have been growing in numbers. This was the statistics at 8 a.m. in the morning today, where we had globally more than 10 lakh cases. The deaths have been more than 53,000. In India, we have about 2,500 cases, and the deaths in India are 72. So probably in India, the numbers are much lesser at present, but we need to be a little more vigilant. We know that the virus is a coronavirus. It is an RNA virus, which is relatively large in size. It's about 60 to 140 nanometers in size. It has got these spike-like projections. That's why it has been called as corona, because of this crown-like appearance that it has. Initially, it was called as 2019 novel coronavirus, but the name has now changed towards the SARS coronavirus 2, because it is more or less similar to the SARS coronavirus 1, which was there. And the disease is called as COVID-19, coronavirus disease 2019. That's the name, COVID-19. The viruses have been there for a while. There have been alpha coronaviruses, beta, gamma, and delta. The alpha coronaviruses and the beta coronaviruses have some viruses which have affected humans. So there are these viruses like 229E or NL63 are the alpha coronaviruses, which have been affecting humans anecdotally, maybe 1 or 2 cases. It is in OC43 is a beta coronavirus, which has affected the maximum amongst the rarer viruses. And of course, the last 3, SARS coronavirus, the Middle East respiratory system coronavirus, and the novel coronavirus are the 3 which have been really affecting the human. So if you see the newer viruses which have been there, the first epidemic which was reported was in 2002 in China by this South Asian respiratory system coronavirus, where the number of cases affected were 8,400 with 11% mortality. The Middle East respiratory system coronavirus was there in 2012, which started from Saudi Arabia. Again, it started from bats and then came to human through domestic camels. The deaths here was about 34%. The number of cases were less, 2,400 cases. But the present virus again started from China. It is believed to start from bats. The intermediate animal seems to be either pangolins or hosts or snakes, but we are not really sure. That's why there is a question mark here. The current cases are more than 10 lakhs with very high death rate, 53,000. The mortality is lesser compared to the earlier two coronaviruses. And if you compare all the viruses, the COVID-19 comes somewhere here. It is, if you consider the reproduction rate as well as the fatality, it comes in between. The fatality is lesser compared to the earlier coronaviruses, as well as its infectivity is lesser compared to the deadly viruses that we had in the past, like polio and smallpox. So it comes in between, but because it's certain feature, it is rather growing rapidly, and I'll be talking about it. The virus has been transmitted through the large droplets, which come through coughing or sneezing. This can also occur in asymptomatic patient, which is more important to remember. And it can also start before the onset of symptoms in a particular patient. That's why the disease is spreading rather rapidly. The droplet spreads only 1 to 2 meters. That's why airborne spread is much lesser, but it gets deposited over the surface, and from where one can touch the surface, and then the virus goes in the body of that person. It remains on those surfaces for certain days. So on plastic, there are some duration. On metal, there is some duration. And then the infection is acquired by inhalation, which is not the common feature. The most common feature is touching the contaminated surface and then touching your nose, mouth, and ear. And that's the most important thing that one has to remember. The fecal transmission has been thought to be one of the factors, but it is not a very classic cause by which the infection has been acquired. And transplacental has not yet been described as yet, but we need to be more vigilant. And it's a simple virus that gets destroyed by simple things like soap or the various sanitizer or even the hydrogen peroxide that we are using. So it's a virus which can be easily killed if you wash your hands properly, use proper sanitizer. The clinical features vary from asymptomatic patient to an ARDS, which goes up to death also. The symptoms are predominantly respiratory, which may be like any other flu-like illness, like patient has fever, cough, sore throat, headache, fatigue, myalgia, breathlessness. A subset of them go at the end of first week, develop the lower respiratory tract infection, pneumonia, respiratory failure, and death can occur in certain patients. If you see in the severe patient, dyspnea would come within 5 days, hospitalization would occur within 1 week, and ARDS would occur within 8 days. So usually, if the patient is going to be bad, he would be bad by the end of first week. ICU admission may be needed in certain patients where they can get acute lung injury, ARDS, shock, and acute kidney injury. A recovery usually, if they are going to recover, would start at the end of second or third week. There have been reports, we know that there are reports of deaths in patients. The deaths are more common in two subgroups. Number one, in elderly, and number two, those who have underlying comorbidities like diabetes, hypertension, COPD, underlying cancers, myelomas, etc. The fatality rate in hospitalized adult patient is 4 to 11%, and the overall case fatality rate is only 2 to 3%. So it is not a very deadly virus, but it is a deadly virus in those who are old and who are in ICU and who have underlying comorbid illnesses. So we know that the virus is predominantly affecting the old people compared to the younger people. And then there are large number of papers which are getting published every day. It is unprecedented that every day NEJM or Lancet or JAMA are publishing papers. And this is the largest series which has been published from China in JAMA. 72,000 patients. You can see that the case fatality is 2.3%. In elderly, it is 14.8%. And if you are in ICU, your death fatality is 49%. So still, if you are in ICU, not everyone is going to die. 50% are going to improve out of this. So it is a virus which can affect predominantly the old people with comorbid patients. The diagnosis is done at present by looking at the throat swab or from the nasopharyngeal swab, but the throat swab positivity is only about 70%. So there are false negative cases which can also occur with throat swab. Better is to take endotracheal aspiration or bronchoalveolar lavage, which is not possible in all the patients. Stool positivity has also been reported in certain people, and if the patient has got severe viremia, even the virus can be seen in the blood also. But it is predominantly the throat or the nasopharyngeal swab which is being presently used for the diagnosis of the viruses. Antibodies can be tested in the serum, but again, it has not been available commercially. We really don't know what will be the positivity of the antibody testing. Majority of them have low lymphocytes like any other viral infection, and CT thorax has been showing various types of patterns, and there are certain patterns which are supposed to be so classic, not so classic about this disease. But being a neurologist, we are not going really about the CT scan of the thorax. Prevention is difficult in this virus because initially the features are non-specific. The infectivity starts even before patient is symptomatic. So you will give the virus to many other people before your symptoms would start. Transmission can also occur from the asymptomatic people, which are more dangerous compared to symptomatic. We know that we can isolate them. There is a long incubation period. The duration is 1 to 2 weeks, and sometimes the transmission can also occur even after clinical recovery. So if you are clinically better, it doesn't mean that you cannot transmit the disease to others. You need to be in isolation even after you are recovered from the clinical symptoms. At present, for prevention, everyone is using isolation, quarantine, frequent hand wash, sanitizers. The PPEs of various types are being used by people. Indian Council has recommended HCQ in the high-risk people for prevention. And at present, we don't have any vaccine. The trials are ongoing. We all know about this. As far as treatment is concerned, if you see, there are more than 3,000 trials which are started for treatment. So the bottom line is we don't have the answer at present. Everyone is trying different things. At the desperate attempts, many drugs have been tried. People have also used plasma of the recovered patient for the treatment of the severe patient. And we know that there are herbal and alternative medicines which have been tried to the treatment. So there are a large number of drugs options have been tried as a desperate attempt. The most talked option is, of course, hydroxychloroquine and chloroquine. It has been demonstrated that they have antiviral activity against the virus in vitro. And there are small trials which have been conducted. Remember that these trials are small trials with serious methodological flaws where they have demonstrated that the virus may be useful, the drug may be useful in the treatment, that they have shown that there is reduction in the exacerbation of pneumonia, there is reduction in the duration of the symptom, as well as the viral clearance is faster with those patients where HCQS and chloroquine has been used. The data at present is insufficient, but because the drugs are available easily, we know how to use the drugs. Many centers have started using these two drugs, and US FDA has approved use of chloroquine in the treatment with so much less available data at present. The other drug which is being used is remdesivir. It is an IV intravenous drug. It is a drug which was used in the treatment of Ebola virus. It is also known to be helpful in patients of SARC and Merck virus. It causes inhibition of the RNA polymerase. So it's a drug which is a potent drug, but again a costly drug not available everywhere at present. The other drug which can be used is a combination of ART, lopinavir and ritonavir has been used. These are protease inhibitors, but we know that there is a recent trial which has been published in NEJM which showed that it is not working, but the trial was a very small trial. People have also used interferon beta as far as treatment is concerned. And then WHO have started a trial. It's a trial where they are going to include thousands and thousands of patients. It's an open label trial where there are 4 arms. One is chloroquine, second is remdesivir, third is the ART, and fourth is ART with interferon beta. This is called as a solidarity trial. Probably this is the largest trial. It would give us some answer. We don't know when, depending on the number of recruitment. When the results will come, we'll know which is the best option at present. And then, of course, other drugs also being tried like fluvir, azithromycin, tocilizumab, certain other antiviral drugs like other ART drugs, ribavirin, favipiravir has been used, and people are also using a lot of other immunomodulatory drugs in the treatment. So at the present, we don't know which is the best drug. There are these options which have been tried as far as treatment is concerned. Now, coming to the neurological features, what we should know as a neurologist about this disease, we know that if you have any viral disease, the neurological manifestation of any viral disease can be of 3 types. Number one, it can be a direct viral infection, which causes neurological manifestation like viral encephalitis, like Japanese encephalitis and other disorders. Secondly, it can cause para-infectious or post-infectious manifestations, like it can cause GBS, it can cause transverse maladies, it can cause edema, etc., which are again well known. And third, it can of course cause secondary to systemic infection, other indirect manifestations like encephalopathy, like seizures, etc. What about these viruses? We know that these viruses are predominantly respiratory virus. Neurology is not the major focus, but the picture may change over the period. We need to be vigilant about this. The neurological manifestations with COVID-19 have been described in certain patients, but again, these are smaller trials. Unfortunately, they are non-English papers, so we really have to read them with a lot of translation, and the data is still emerging. Every day we are getting new data. The largest trial, and of course, we have to understand there are no large papers, and people like Green Journal, they are asking, send us paper, send us data, we will expedite your peer review and publish it immediately. This is an advertisement which has come in Green Journal that they want data. Everyone wants data because no one knows what is an answer. So everyone is looking for data. You have one case, please publish it. You have two cases, please send it. We will publish within 2 days. New England is publishing papers within 2 or 3 days. So everyone wants data here. The largest trial which is published has been of 214 patients. 88% of these were severe patients. They said that the neurological manifestation was seen in 36%, more than 1/3 of the patients. But if you see carefully, they had encephalopathy, which was part of the metabolic encephalopathy, seen in about 14% of the patients. They had headache, which can be a very non-specific manifestation of many flu-like illnesses, which was seen in 17% of the patients. They had dizziness, around 20% of the patients. And they had what is called as muscle injury. Again, this muscle injury has not been described well in this paper. They had patients where CPK was high. We don't have histopathological data. We don't have any EMG data in these patients. Some of them may be having just a non-specific rhabdomyolysis-like illness. So if you see neurological manifestation, encephalopathy 14%, headache 17%, dizziness 20%, muscle injury 20%. That takes around 75 to 80% of the patient. What about the remaining patient? There was strokes. Strokes were seen in 2.8% of all patients, 5.7% of severe patients. But remember that the severe patients were the old people who had a lot of comorbidities like diabetes, hypertension, COPD. So we know that these old people are likely to get strokes. So we really don't know whether the strokes were due to the illness or it were because they had other illnesses they got the stroke. And then of course there were about 3 to 4% patients, 5% patients had hyperosmia. There was anosmia, and I'll talk about it later also. And then they had 1% ataxia, 1% seizures, 1 or 2% pains like neuralgia. So if you really read this paper carefully, there was hardly the clear neurological manifestation in these patients. Then there was this paper which was published about single case report of a patient who had past history of stroke who presented with encephalopathy, and the CT scan showed old infarct, CSF showed 68 protein 4 cells. So this is probably the first report of CSF in a patient of COVID. They could not do PCR of the CSF in these patients, and the EEG showed some typical slowing in some of these patients. So this patient clearly had a metabolic encephalopathy with a past history of stroke, and this patient, when they had written the paper, the patient was still in ICU in a critical state. And then, of course, 2 days ago, we had the first reported case of encephalitis, where we have MRI findings of an encephalitis in a patient of COVID. This is the first probably paper which is true neurological paper, where we can see that their patient has bilateral thalamic lesions, where hemorrhages were there in the thalamus, and they also had bilateral temporal lesions when there were some hemorrhages in the temporal. This patient had an encephalitic illness, and this encephalitic pattern is called as acute necrotizing encephalitis. This is seen with cytokine storm in many disorders where you have acute worsening in these patients. And similar findings have been reported in flu, H1N1. And you can see that this is one of our patients of H1N1. We did not see COVID, of course. We had seen this H1N1 patient where patient had bilateral symmetrical hemorrhagic thalamic lesion. So this is more or less like our patient that we had seen. Personally, I had seen this patient. So we can get acute necrotizing encephalitis in some of these patients, but at present there is only one report which has been reported just 3 days ago on 1st of April. And then we had experience from the previous illnesses. The SARS coronavirus particles were being demonstrated in neurons in some of the patients. Again, there is a Japanese paper in 2005. Experimentally, in an animal, when they injected this particles in the nose of the patient, through the nose, through the olfactory nerve, it entered in the brain of these animals, in the mice, and then it infected the brainstem and thalamus. So this anosmia or entry through the olfactory nerve may be an important clue for us. And then, of course, there were reported edema cases with this MERS in 2015. So with the previous 2 viruses, there was some neuroinvasion seen and some neurological manifestation seen with some of these older. What about other coronaviruses? Well, there are isolated case reports of involvement because of these other coronaviruses. There are 2 or 3 papers where in children with this coronavirus, OC43, that they had encephalitic illness, and majority of the patients were pediatric, and they had demonstrated this OC43 in the CSF of these children. And this is another paper which comes from China. I don't know what is the relation of China with coronavirus. All the coronavirus paper related comes from China. So this is a paper which was published in 2016, where they looked at children who presented with encephalitic illness, and they looked at the coronavirus IgM antibodies of these children in the serum, and they could see that in 12% of the patients, in the patient. So some of the cases of acute encephalitic illness in children could be because of coronavirus. That's what this paper claims. But this is only one paper. We really have no further papers of this kind in last 4 years. And then there is another view. This is the paper again which comes from China. This says that the virus is known to be neuroinvasive. It is going and involving the brainstem, and some of these patients who get respiratory failure need not be having only ARDS. The respiratory failure can be because of central involvement in the brainstem. So this is another interesting view which comes, that the neuroinvasion can actually be the cause of respiratory failure, the central respiratory failure. So we don't know whether this is true. It is too early. It is just a speculation at present. But this is an interesting hypothesis that we have to understand. And then what about anosmia? Anosmia is seen in about 3 to 5% of the patient. We know that any flu-like illness can cause anosmia because of involvement of the local nose, but some of the part of anosmia can be neurological. We don't know how much of it is neurological. And coronaviruses are known to enter a nose through the olfactory nerve in the CNS. And we know that in disorders like Parkinson's disease, where patient can get anosmia, which can be a manifestation before onset of Parkinson's. So it is an interesting hypothesis that some of these patients may get neurodegenerative disorders in the future. We really don't know. And if they enter through the nose, immediately can they cause encephalitic illness? Again, an interesting hypothesis. We really don't know, but we have to really be watching out for this. At present, where we stand today, there are no positive PCR reports from the CSF in the world as yet. There are no post-mortem data of the brain as yet. There is no report to suggest that there is intrathecal synthesis of the antibodies of the coronavirus in the CSF as yet. There is only one report of MRI at present. So at present, the data about neurological involvement is rather scratchy. We need to be really vigilant. But we have learned our lessons. We have burnt our fingers 15 years ago when we had first chikungunya encephalitis epidemic in India, where it was thought that the virus is non-neurotropic, and then every one of us has seen lots and lots of cases. So, and then it was known that this virus is neurotropic. So we need to be really vigilant even when we get a new viral infection, that something new which comes up, we must think that whether it is related to the virus. What can be expected? Well, we can expect strokes, we can get metabolic encephalopathies. We know that the virus can cause neuroinvasion. So some encephalitis can occur. Post and para-infectious phenomenon like GPS and ADEM can occur. And whether we are going to get patients of Parkinson and dementia as a late sequelae because the virus is going through nose is again an hypothesis. What we know, what about our existing patients? This is about what I talked was about because of disease. What happens to our existing patient? All of us have pools of patients, and we know that the disease is particularly more dangerous in people who are old with underlying neurological disorders. So this is what we are dealing every day: Parkinson patient, stroke patient, dementia patient, and people who have difficulty in clearing the secretion. Those who aspirate are again at higher risk. And epileptic patients, seizures can be triggered because of a febrile illness. So our patients are at risk. And the British Neurological Guidance Association has come up with this guideline that certain patients are at higher risk, like motor neuron disease, myasthenia gravis, NMOSD, Duchenne muscular dystrophy, spinomuscular atrophy. These are the patients who are at high risk of getting infection, and because they are having difficulty in swallowing, they can go in ICU faster. Moderate risk is seen with GBS and other inflammatory polymyositis and limb-girdle muscular dystrophy. MS, spinocerebellar ataxia, traumatic brain injury, the risk is seen to be moderate. And the risk is low in patients who have epilepsy, cerebral palsy, and CIDP. In strokes, the risk can be from high risk to the low risk depending upon where is the stroke and how severe is the stroke. And same will apply to movement disorders and dementia, where the risk can be high in someone who has got a PSP with a feeding gastrostomy versus someone who has got a mild Parkinson's disease and who is ambulatory. So the risk can be varied in these strokes and movement disorder patients. What about drugs? Well, at present, there is no data available as whether we should stop some drugs or whether we should continue the drugs. It is unclear at present as what advice we would give to our patient. But we know that severe immunosuppression can be problematic at times in some of the patients. There is another interesting hypothesis that says that ARDS actually can be partly immunopathogenic, and pro-inflammatory cytokines, cytokine storm, infiltrate, trigger this infection, and they can cause damage in some of the patients. So immunosuppression actually may be beneficial in some of the patients, and it has been believed that fingolimod may be preventive in some of the patients. Again, a speculation. Tocilizumab has been used in certain patients of COVID infection, but we don't know whether these drugs are really going to be beneficial in our patient. But we don't know which drug is better, which drug is not better. So again, certain recommendations can be done, like drugs like interferons, oral DMTs, natalizumab, azathioprine, mycophenolate, and steroids can be used. ACE inhibitors, there was a doubt about ACE inhibitors because this virus is known to enter the pulmonary cells, respiratory cells through the ACE2 receptor, and ACE inhibitors do not completely stop these ACE2 receptors. So ACE inhibitors can be continued at present. That's the current recommendation, but it may change. Drugs like rituximab, alentuzumab are known to increase viral infection. So it is being recommended at present that if your patient is on rituximab and if it is not hurry, please postpone the injection for a while. Bone marrow transplant also should not be done during this period. And then there was some data about ibuprofen saying that if you use ibuprofen, it reduces the number of ACE2 receptors and increases the ACE2 expression, and the infection can worsen. So ibuprofen at present is suggested to be avoided in certain patients. So what will be the impact on us as a neurologist? First, of course, we know that there is impact on our OPDs. We are avoiding face-to-face visits with our patients. We are giving prescription in old patients with SMS, mail, and WhatsApp. And various medical organizations have allowed us to give prescription on SMS as well as WhatsApp. The IPD services are also been hampered. Routine admissions have to be avoided. And we know that certain hospitals where there are particular neuro beds, the beds have to be relocated and they have to be given to this patient who will be suffering from COVID if we are really going to get a large number of patients. And of course, because we have to avoid face-to-face interaction with patient, teleneurologists come up in a big way, and we know that there are now lectures also being published and given on teleneurology, and we all must know about how to use teleneurology. And of course, there are going to be no conferences. So many conferences like Stroke Conference, like ICTRIMS, like American Academy, like European Academy are cancelled, and probably we are going towards this webinar and Zoom. And I must congratulate IN office bearers to start this kind of activity. And I'm sure this kind of activity would continue in future also. So as far as possible, try to avoid physical doctor-patient interaction. And all of us must be ready to work in non-neurology departments if need arises in future. So every one of us must be ready for this. Lastly, what ask COVID patient? What do I expect? Number one, when you go to see a patient who has COVID and he has neurological manifestation, it can be an indirect effect of organ involvement. It can be an encephalitic illness, or it can be a post-infectious immune-mediated illness. We are entering really an unknown territory, and we must keep our antennas up. So remember that if you see something which is new, something which is unusual, and something which comes in crops, think that it may be related to the present infection of COVID. So keep your antennas on. Take-home message: neurological manifestation at present are less. The commonest manifestation at present are metabolic encephalopathy and strokes, but the numbers are changing. Coronavirus are known to invade brain, and encephalitis and similar illnesses can occur in some of the patients. Post-infection manifestation would come not immediately, maybe after a few weeks, and keep a watch about new unusual features in your future. I leave you with two papers. Think about these papers. This is a paper which has been published in New England Journal just 2 days ago, which says it asks two questions. Number one, will the things go back the way they were earlier? And most of the people think that no, the things would remain changed. And what things that we are doing now, like this webinar, will they be considered as part of our new normal? And the probably answer is yes. We would all change, and the change would continue to remain. And then you see this paper, Continuum has published a paper. Continuum is one of the premium journal. It has published a paper of June 2020, ahead by 3 months. And the paper is about non-face-to-face evaluation and management care of the patient. How you should use teleneurology in your practice. They have published a paper 3 months ago. It is really unprecedented that a Continuum paper comes 3 months ago, talks about non-face-to-face evaluation of patient. So there is no doubt that the world is changing, the doctors are changing, and the neurology also is changing. I think I'll stop here. Thank you.
Thank you, Rahul. Am I audible now?
Hello.
Hello.
Okay.
Thank you, Rahul.
Thank you.
Yeah. Nirmal, go ahead.
Thank you, Rahul. So we have the second talk. So question and answer are coming. You can still continue to send your questions.
We can't hear you well.
You can't hear me? What is happening, man? Hello?
We can't hear you well, Nirmal.
You can't hear me?
No, your voice sounds strangled.
I don't know. I'm trying.
Yeah, now it's better. You need to come closer and talk then.
Yeah. So keep on sending your question and answer. We are getting that. We have quite a few question and answer. We invite Nitin Sethi now, the next speaker, and then we'll take the question and answer from both of them. And Nitin, of course, is a neurologist in New York, and Are you ready with your presentation, Nitin?
Nitin?
Sorry, I can't hear you so well.
Are you ready with your presentation?
Dr. Nitin, are you ready with your presentation?
I actually have no presentation. I'd just like to give you some of my thoughts about what's happening in New York and some of our experiences here, initial experiences, and that might probably be of help. So in New York, we started seeing the first cases, I would say probably the beginning of March. And it's just surprising what I feel, what is probably a big point for me is just how rapidly things changed in the space of maybe about 10 days, where we went from having just a few cases coming in to suddenly the entire city just getting shut down and just flood of cases right now. So one thing is that what I feel, and this virus kind of tends to linger, you know, at a subclinical level in the community for a while. So there's some community transmission which is occurring, and then at some point in time it just kind of manifests itself. And when it manifests itself, it's just a flood of cases which come into the hospitals. It's not as the doctor said, it's the management of the disease itself is relatively straightforward. It's just that the healthcare system gets overwhelmed by just the sheer number of volume of cases. So for example, I'll give you something like maths I did in a city like New York City has about 8.5 million people. Let's assume that about 100,000 people get affected. And let's assume that out of that, 60,000 just recover by themselves. You know, they're isolated and they just have a recovery. They don't even come to clinical manifestation. But let's assume 40,000 people suddenly come to the hospitals. And out of that, 10,000 need admission. You can imagine that no city will have, and let's assume even 4,000 need ventilator beds. You can imagine no city will have 4,000 ventilators and ICU beds available. So it's just what really hits hard is the sheer volume of cases which come, and they just tend to overwhelm healthcare resources. They have done so in Italy, in Spain, and even in New York City. So what we realized was what's happening here is pretty much as we started getting this news, the hospital pretty much was emptied out. Literally all non-essential inpatient medicine came to an end. Inpatient neurology was just stopped. You know, things like epilepsy monitoring unit shut down. You know, outpatient services came to a complete halt in the sense we were not doing our OPDs. They pretty much stopped. And right now, nearly the entire hospital is devoted, in many hospitals are completely devoted to the care of COVID patients. Multiple floors have been converted into ICU units. So as much so like the operating rooms have been converted into ICUs. Outpatient services like where you have endoscopy suite for upper GI or lower GI endoscopy, that has been converted into, you know, sort of critical care beds. So as the doctor mentioned, we have been now redeployed even as neurologists to help with medicine. And, you know, I personally have now got orders that for the next 4 weeks, I'll be completely integrated into the medicine service. I'll be relieved of my duties as a neurologist, and we will be deployed into medicine. And, you know, whether the teams are made to cover the emergency department or the critical care units or other inpatient medicine units. So that's where it really hits you. You think you are prepared, but the sheer volume of cases which come in, they just tend to kind of just completely cover your, you know, inundate your services. As regarding neurology, you know, we are having morning reports. They are being done through Zoom. So everything kind of moved to Zoom. Grand rounds moved to Zoom. You know, medical schools were shut down. Our fellows have been upgraded to the level of attending. So now the fellows have been upgraded to attendants. medical students, final year medical students were graduated ahead of time and said, and asked, if you want to volunteer, would you like to join this battle against COVID? So you can really imagine how things have changed in USA. In America, HIPAA is it's a very strong law, which kind of, there's a lot of ways where you have to have privacy for patient information. HIPAA was suspended, which is unprecedented. So we are now allowed to do Zoom meetings with our patients, FaceTime, WhatsApp, and that's never was expected in America. Now, as I'm attending the morning reports, we are started seeing some neurological patients coming in. So myasthenia gravis patients coming in with acute exacerbation of myasthenia, and they are COVID-19 positive. So they're going on ventilators. Now, whether it's COVID-19 which is causing the myasthenia acute exacerbation, and how do you really treat it? Do you give them steroids at that time? Do you hold off from the steroids? Do you do IV, IG? These are all thoughts which we really we are thinking. We don't know the answers. Patient coming in with a carotid artery dissection, and she had been sick with COVID-19 and she'd been coughing violently. So some strokes patients coming in, COVID-19 positive, GBS patients presenting. So we are seeing some atypical GBS-like presentations. And really right now, as it stands in New York, you are COVID positive until proven otherwise. So even the testing has changed. So let's assume you go to the hospital and say, I think I'm having COVID manifestations. I have a bad cough, I have fever, myalgia. They will say, well, listen, you look stable, go home. We are not going to even test you. We're going to say, go home and you isolate yourself, take medicines, paracetamol over the counter for headaches, for body aches. And, that's what we're doing. But if you are, for example, once you come to the hospital and you are unstable, your oxygen saturations are low, you look as in respiratory distress, and the decision is made to admit you, then we are testing you, because we need to determine which room you go into, isolation, not isolation, ICU. So, the testing also is changing very rapidly. There's so many new tests coming out. So, like, for example, some of the doctors had asked in our meeting, like, for example, I'm going to the ICU unit. I'm not sure if I have COVID. Can you test me and see if I'm already infected and I'm now immune? The thinking is that, if you get infected with COVID, after a week, after about 2 weeks or so, when you start, if you're IgG positive, that means you are now probably generating immune response against COVID-19. So, how do you protect the healthcare workers? Doctors are getting infected, nurses are getting infected. And like a simple thing which I'll tell you, you have a patient who comes into your hospital, gets admitted right now, probably is already admitted, and you don't even know the patient is COVID positive. Now, by the time you come to know he or she is COVID positive, the entire ward has been exposed to that patient, and now the entire ward has to be quarantined. All the doctors, all the resident doctors who have come in contact with the patient have to be now probably quarantined. So you can lose your healthcare services and your force very, very quickly. So really, at the moment, my suggestions or my thoughts will be, you must probably think about every patient coming to the hospital should have a basic screener that you try to figure out that if somebody might be COVID positive, does somebody need to be isolated and checked before they are just allowed to get admitted into the hospital. In a lot of the data which later came out from China, there was a concern that actually the virus spread inside the hospital because of transmission from patient to patient, which might have occurred while the patient is transported. So let's assume you want to transport the patient for an MRI. When you take the patient from the room to the MRI, everybody has to wear personal protective equipment. That's a lot of equipment which people have to wear. Once you have the MRI, that MRI takes about 1 hour to kind of, to wipe that MRI down for a new patient. So pretty much all outpatient testing has been suspended. Can you do your neurology without requesting the MRI? will it change the management? Will an EEG change the management? Do you think really this patient needs an EEG? Because fine, he has encephalopathy and might be COVID positive, but when you do the EEG, that technician who goes down, he or she can be exposed to the virus. He or she has to be protected with personal protective equipment. So really the thinking as a neurologist has to change, that whether the tests are being ordered, can we do it without the test? And regarding, so in hospitals, what we have done is you have teams which have been created. So another thing which I learned, like for example, intubation has to be very, very controlled. You don't want to be intubating these patients in the casualty or in the middle of the night, because when you intubate, you generate a lot of aerosols, and that intubation team, that anesthesiologist, that resident doctor in the night is very, very high risk of getting the infection. So, intubation has to be controlled. Now, when you're putting them on oxygen, when you go beyond 5 liters of oxygen, you again generating a lot of aerosols. So, anybody in that, if that patient is not in a negative pressure room, anybody who goes into a room is at a very high risk for infection. So as if you go for your rounds and the patient is on oxygen, nasal cannula, high flow, you can get infected. CPAP, people want CPAP, again, you have to be very careful. Aerosols are generated. So whether you use some sort of interface over the CPAP, like a head interface, all these things we have to figure out very quickly and try to address them, because what we fear is that the high risks of exposure to healthcare workers. And in America and around the countries around the world, we have lost a lot of our colleagues, a lot of nurses to this virus, because it does cause very rapidly in some patients in ARDS like presentation.
Have you finished, Nitin?
Yes, I'm done.
Oh, thank you. So I would have one question for you. The gentleman has asked you, what would you have done in USA to prevent the spread into the community, or rather what you have been doing now that further community transmission do not happen in USA? So could you answer that? I know you have answered part of it, but could you further answer that?
No, I think what I honestly have been telling everybody that I think what Prime Minister Modi did, even though there have been some negative comments, was what was needed. It was a all or none response. Now, Prime Minister Modi made a call and he shut India down, right after Holi. Now, we can only hope that that was done at the right time, not too late. Because if the virus has already spread widely in the community, it will certainly suddenly come in like a wave, like I said, like a tsunami suddenly rises up and will hit us. So I think what happened in USA was America never really completely shut down. You can still fly into America. You can still fly out of America. Inside America, you can travel. I can kind of, drive and get into a car or train and go into a part of America, where the virus is not so widespread. But then I can transmit it to that part of America. So really what Prime Minister Modi did, which was basically isolate, shelter in place. Wherever you are, you're sheltering. You are not getting out from there. And then once the healthcare providers start identifying cases, you isolate them, you test them, test their contacts, and try to stop the spread of the disease. Because in India, if this spreads, our population, I did my MBBS from Maulana Azad, LNJP hospital, huge hospital, but even on a good day, half the ventilators are not working. And whatever ventilators are working are already occupied. So you can imagine how hard it will be for any of us to manage this disease if it spreads in India. It's not the disease itself. The disease management is easy. It's mostly, like you said, it's respiratory management. It's the sheer volume which comes, where then you start having people dying right in front of you because you don't have resources.
I agree, Nitin, because I get everyday update from my daughter from New York, and she said that the Manhattan, the number of cases are definitely less now. It's not increasing, but the new places where it has been increasing is New Orleans, Detroit, and now the Miami, because even the beaches were open till last week. So I think what you are saying that Prime Minister Modi has done the lockdown, that has probably
what even still the US is open and you can fly. I think that may be the reason that you are seeing more cases, or you are seeing more cases because you are doing now 1.5 lakh testing every day.
That is true. The testing has changed. Like earlier on when they started, we were doing testing in the community. So they were like drive-through. You could drive through and you'll be tested. Then, you know, what happened was even actually going to patients' home and testing them. But now then we realize it's so widespread that whether you are positive or negative, if you are stable, it does not change the management. I would just say go home and isolate. It's when you become sick and you come to the hospital and the decision has been made that you have to be admitted, then you need to be tested because it might change the management. It will change what kind of bed you go to, isolation bed or a regular bed. So I think that even the testing right now might change based on exactly how many cases you have. If it's a widespread community transmission, then the testing really does not have much value because everybody starts getting it.
Thanks, Nitin.
Wonderful.
There is a question for Rahul. Rahul, you're online.
I can take them. Yeah.
Yeah. So the first question is Dr. Krishnamurthy wants to know that if you have a patient with status epilepticus and fever, should you treat him as COVID-19 positive?
The present recommendation of the government says that someone who has illness, which is a respiratory illness, he or she only should be tested for COVID. So someone who comes only with status epilepticus or a stroke, and then there is some fever without respiratory symptoms, probably one would not test at present in these patients. But of course, the recommendation may change over time.
Okay. So the next question is from Joy Desai. And this could, maybe any of you can answer, Nitin or Rahul. Do let us know if encephalitis has already been described. Encephalitis, any specific features therein?
As I said, there is one patient which has been 31st of March, paper was published on 1st of April, 3 days back. The paper said that this was an old patient who came from Michigan, Detroit. And this patient presented with encephalitic illness. There were MRI showed bilateral thalamic and the temporal lesion, some enhancement, and there was some hemorrhage in the lesion. They could not do CSF PCR of this patient. The patient did not do well. And then it was said that the patient had this acute necrotizing encephalopathy rather than true encephalitis. But then, yes, this was the only paper which has been published till date. Only one case published 3 days back. It is acute necrotizing encephalopathy, and it is supposed to be because of cytokine storm.
But we see that this double donut sign, we see that even in dengue encephalitis, Rahul. You showed a patient with H1N1.
Yeah, we have seen this with many disorders. We see this with dengue, we see this with influenza. Classically, this kind of disease has been described with influenza, but we know that in India, we get this with many arboviruses as well.
There is a comment from Dr. Jairaj Pandyan from Ludhiana. He says that we may not be able to prove the neurological manifestations with the current testing guidelines. He says he has a patient with atypical GBS with fever, and the government lab refused to do CSF testing.
Presently, none of the lab is doing CSF testing. What they are doing is the throat swab. Over the time, once private labs would open or the present labs, if they start taking more load, they may start doing these kind of tests. As I said, we really don't know how many of the new GPS or the atypical GPS that all of us are seeing are related to the disease. So one option is we can keep the CSF sample of these patients preserved and use it for the later test. Or else, if you keep seeing same kind of patient again and again, think that it may be related. But of course, we need to be vigilant at present. One really can't be sure whether it is really because of the disease or it is not because of the disease at present. It is an unsure thing.
Yeah, so Jairaj also has another comment. He wants to know, he says that getting an MRI will be challenging. Your patient presents with encephalopathy.
It's very true. It has to be a patient who is in ICU, who has shock, and then he's in isolation, then you have to move the patient to the MRI department. It is really going to be a challenging task.
Like Nitin said, everyone needs to wear PPE and you need to actually disinfect the whole MRI after it's done. So it would be challenging. Dr. Ritesh Sahu wants to know the role of steroid in COVID encephalitis.
Again, there was a trial which initially they tried to do with steroids. Steroids are not to be found to be beneficial. The British guidelines say that someone who is on steroids some other reason, like his previous neurological illness, and if the steroid dose is more than 20, he is little bit at higher risk. So at present, the role of steroid is controversial, and largely the Chinese people initially used steroids, but now most of the Western world has given up steroids, I think.
So there are a couple of questions for Nitin. Can we ask Nitin Meenakshi, if you allow me?
Yes, yes, please go on.
Tapas is from Calcutta is asking whether what are the age and gender of the critical ill patients, and Dr. Sheikh has asked you whether you have taken a HCQ precaution.
No, I don't. I have not taken the hydroxychloroquine and zithromax. I personally feel, and I'm pretty convinced, I already had it. I have a very healthy respect for what I experienced from this disease. But one thing, like I like to say, like a point where neurologists can help and how we are helping. Everybody has to play a part. We are not called to actually serve as internists, but like for example, what we have done is I do epilepsy. I've called all the epilepsy patients and put them on, a little bit of lorazepam or intranasal midazolam to prevent them, on top of their standing anticonvulsant, prevent them from coming to the hospital with status. This is not the time I tell my patients that you want to be landing up in the hospital with status epilepticus. One, we don't have beds. All our beds are being used for COVID-19 patients. Secondly, there's a very high chance that you'll get infected if you're in the hospital. So really, as Dr. Rahul had said, you really have to think about neurology going completely outpatient and trying to manage all your patients on outpatient basis and protect yourself also, because you might have a patient who comes into your office, you do a consultation, and next thing you know, after some time, the patient was positive. So really, you have to probably protect it, just like Prime Minister Modi is saying, you got to protect, everybody needs to shelter in place for the next few days. In a way, practice comes to a stop. And so, for example, all the surgeons here have nothing to do. So if you're not fighting the COVID battle, you're basically sitting at home because there's no elective surgeries going on. There's no elective neurosurgeries going on. So you really have to be prepared to be in that sort of a change of the workflow.
So there's one more. Amitabh Verma has asked whether yesterday New York Times mentioned that some Belgian patient presented. Hello.
Hello.
Yes, sir.
Yeah.
Yes, sir.
Yeah. So Meenakshi, you take over because I was disconnected.
Mine is also, my video, it's okay. Can you hear me? Okay, there is a
Yes, sir,
question
we-
about, yeah.
Can hear you.
There's a question about the legality of the WhatsApp consultation, and Dr. Pramod Paul would like to answer that. Pramod, please. Is Dr. Pramod Paul online?
Okay, no, I don't think Pramod is there, but
Yeah, because it's got disconnected. Let's take
Hello.
the Rahul question.
yeah,
Hello, can you hear?
there is something known as an Epidemic Act, and under the Epidemic Act of India, WhatsApp consultations and can be treated as legal. I mean, there is no issue about it.
So
That's
there is
what-
a Government of India guidelines which has come
yeah,
last
we
week.
need to follow
and
those
which
guidelines.
has clearly guided that you can have audio, visual, on email consultation. And in fact, they have allowed you that you can charge as much as you are charging for the consultation. So
Yeah, but the other question is, the other question people keep asking is, can you send prescriptions also?
absolutely, you can, because you need to have the
Okay.
record of your prescription, your discussion with the patient. And I propose next week I will take a lecture on that, because telemedicine would be very, very interesting. And there are a lot of things has come in. There is one question which has come in that what about the ACE inhibitor, Rahul? What is happening with the ACE inhibitor and ibuprofen in COVID? Are they creating more problem? Could you answer that?
So there was some issue about ACE inhibitors, but of course, neurologists are not directly affected with ACE. But if if you go to the guidelines which have been given by various European societies which deal with hypertension, all of them are saying that you must continue your ACE inhibitors. You don't have to stop them. And as far as
inhibitors and ARBs.
Yeah, and as far as ibuprofen, there is some data to say that some of the patients who had developed this disease had prior exposure to ibuprofen. That's why there are some recommendations which are coming in saying that ibuprofen may not be a good drug if you get febrile illness. Better to take plain paracetamol.
So there is one question from Pritika Chari. She is asking whether do Indians have the herd immunity? What is the role of your BCG or malaria? Because there was some big news by the WHO that countries which have malaria rampant like Africa, India, the severity of the infection is far less. So could you highlight on that?
I am not expert to talk about this disease. This is an entity at present, to be honest. Let us probably stick to only neurology discussion.
Absolutely.
We won't be able to talk about this, to be honest.
So Pritika, we are sorry, we will not be able to discuss on this.
I believe there's a small trial which is going on in Australia where they have taken healthcare workers. Half of them have been vaccinated with BCG and the other half have not been, to see whether BCG gives some sort of a protective immunity to this virus. And the thinking is that people who get BCG or vaccinated, countries where BCG vaccination is very well done, like Japan, South Korea, that some of these people mount a more robust response to this virus. And it's, but like I agree, that's not really, we still don't know the answers there.
So I think
Meenakshi, carry on.
Yeah, I think most of the questions are done.
Except that one person has asked, what is the status of using N95 mask when there are many other way of infection being transmitted?
Again, this is probably not a question for a neurologist. We need some non-neurology expert about ID who can speak in this forum at some present moment in the present future, and he or she can answer such questions probably.
I think by what happened is because Rahul, a lot of people are apprehensive, so they really want to know how they should do. And I think they are right also, because everybody will have some fear that, you know, we are seeing the patient, what should we do? I think maybe we need somebody to also guide on that. Of course, the guidelines are available on the website of Health Ministry.
Dr. Umar Kadan wants to know about that case, about that encephalitis case. He says MRI does look like a deep venous sinus thrombosis, deep vein thrombosis in the brain. Was an MRV done in that case?
I didn't show the images. They initially did a CT with CT angio and a CTV, which ruled out thrombosis. The paper has been published in Radiology Journal. So, you know, it's a radiology paper, which is about a 2 pages paper, which talks that there was no deep vein thrombosis. They did a CT and CTV initially.
And Dr. Chaurashia wants to know, what is the role of IVIG in COVID encephalopathy or GBS?
Again, as I said, in the desperate situation, everyone would use these drugs. And the JAMA paper, which I quoted, which is about 77,000 patient paper, Chinese people have used IVIG in some of these patients. It is not mentioned whether it was for GBS or for encephalopathy. Of course, if you get a GBS-like illness, one would treat like any other post-infectious neurological disorder with IVIG. Whether it is going to be helpful for encephalopathy, we really don't have answer at present. But there are people who have used it in the past.
Always do we have time?
Somebody asked about high dose of IVIG. Dr. Ramdas wants to know.
No, I really don't have any answer for that at present, to be honest.
Meenakshi?
Yeah.
Meenakshi?
Yes, sir. Please go ahead.
I couldn't type the answers. Can I ask Nitin a quick question? That what is the mean duration of hospital stay in New York, and how long the infectivity lasts after discharge?
So the one thing which the feedback I'm getting from some of my colleagues who are doing critical care and ER is that a lot of these patients, you end up intubating them just because they're in so acute respiratory distress. There's a hypoxic respiratory failure. You know, they are coming in with oxygen saturations in the 80s. And once you end up intubating them, when they go on the ventilator, they can be on the ventilator from anywhere between a week to 3 weeks time. So you end up tying your ventilators down also very quickly. That's another problem which is there, that you may have enough ventilators, but very quickly you run out of ventilators and you run out of ICU beds.
And how long is the infectivity after so-called cure? Means, do you test second time, third time before you send them home?
No, we don't test them. It's the thinking is that people who are once you have if you have COVID-19, you are quarantined for about 14 days. And as if you have been afebrile for 3 days, you can probably begin a sort of a return to work. This is more for healthcare workers. But it's also the other studies which have shown that people may be asymptomatic and still be shedding viruses. So you might still pick up the virus in a person who is kind of recovered. But the feeling is that they're most infective early on in the clinical manifestation rather than later on.
Okay, I think we can thank.
Is it kind of time?
Yes, sir. There is.
So there are a lot of questions.
Oh, okay.
Yes, so we've kept a buffer of another 20 minutes. So till 1:30.
Okay, in that case you can. Yeah, sure. Then you continue.
Hello.
So many of these questions are repeat. Pramod, you wanted to say something?
No, I thought that, no, I have asked the question and I thought that Gagandeep wants to, the time constant was there, but now there are 20 minutes left. So we can, I think, continue if anyone wants.
So there is one question which is by Dr. Manoj, is analysis study on mortality in non-neuro cases? Rahul, you have something like that?
Yeah, the paper that I quoted had 214 patients. 88 of these were severe patients. And as I said, again, in those patients, the predominant feature was encephalopathy, seen in about 7% of the milder cases and 15% of the severe cases. Headache, dizziness probably were more or less same in numbers. So those patients who were more severe and more neurological manifestation, which is bound to happen. There is no data about mortality per se in neurological patients, because the mortality was not because of neurology. It was because of the previous illness.
Yeah. So there's one more question from Dr. Reddy, who is asking any recommendation for continuation of methotrexate for people who are already on it while they get it COVID?
The data about use of continuation of immunosuppression is not yet. People have continued, if the patient have been on single immunosuppressant, they have continued it. That's what the British guidelines says. But if someone is on multiple drugs, high dose of steroid, then he or she is at higher risk. Methotrexate.
Yeah. So there is one question from Dr. Sangal. Is there an emergence of opinion that anosmia, perhaps consequent ageusia, is pathognomic of COVID?
So in the paper, the people who had anosmia was about 5%. It may, and some of them also had loss of taste sensation. So there is one hypothesis that suggests that the virus can be entering through the taste buds as well as through the olfactory nerve. So it may be that anosmia may be an important feature, but we know that many flu-like illnesses can, because of local mucosal damage, can also cause anosmia. So how much of it is because of local mucosal damage and how much is because of olfactory nerve per se involvement, we really don't know the answer.
But your paper suggests only 8 to 10% patient has anosmia.
3 to 5% patients in that
3
paper.
to 5.
Yeah.
So Nitin, Dr. Joy want to know, should we promulgate a concept of presumed positive for all patients in this pandemic and proceed accordingly?
I personally feel right now, till we come to know whether how I think the only problem in India right now, you must understand, is that the testing is, if you take our population, it's really no testing really. We are hardly testing any percentage of our population. So how much is the community transmission already? We don't know. We're just guessing. So I personally feel that every patient who comes into the hospital, Like for example, in the night you have a transfer from a different hospital, and that patient later tests positive. Every healthcare provider who was exposed to that patient, every resident doctor has now got potential COVID exposure. So I think every patient who comes into the hospital should be thought to be COVID positive, and at least if the testing has not been done, some basics screener asking the 4 or 5 main questions: do you have any fever? Do you have anything, any myalgias? Do you have any rash? You know, at least that should be done. And probably every patient who comes into the hospital should be wearing a mask.
Perfect.
Can I ask one question to Nitin?
Yes, why not?
Yeah, Dr. Nitin, there was one report or suggestion of testing the antibodies to see what is the subclinical infections. Is anyone doing it? Antibody?
No, we are not really doing the antibody right now. The tests are changing so rapidly. You know, now they have every day a new test is coming out, and even with the testing, the sensitivity of these tests is somewhere in the range about 70%. So, you know, even if you go and say, I got myself tested, I'm positive or negative, there's a little bit of a catch to that. How sensitive is the test? So while testing strategy has to be incorporated into the COVID-19 management in the community, you really have to decide which people you're going to test in India. Whether you're going to start testing, I think it's reasonable if you have resources to start testing your patients in the hospital who are coming inside, inpatients, that you don't admit a COVID-19 patient and potentially infect the whole hospital.
That's something I think, Dr. Nitin, that we are doing in India right now. What is happening is, like you said, if someone comes with a problem, someone has a problem, he said, okay, you go isolate yourself. If you have symptoms, you come back, we'll test you. I think that's what is happening right now. And I think that is best, the reservation of resources that's happening now. So if they are symptomatic, they are tested. Somebody has suggested increase in testing. I don't know what that means. You can't go and do it in the community, you know. That is probably not something that anyone can do. Maybe South Korea did it, but we can't do it.
So there is one last question I'm asking. Rahul, somebody
Yes.
wants to know what is the reinfection rate. Are there any data now? China opened the flight and then they again reclosed and they got some new cases. So do you think
That is important.
There is some data of reinfection which is emerging from China. But again, as I said, we are in early waters. We really don't know what is the reinfection rate. If there is going to be reinfection, it's rather dangerous because then the vaccine and all are not going to work. So we hope that the reinfection rates are not going to be very high. But at present, the answer is we don't know.
Okay.
And there is a comment from somebody, a doctor in the army, in our Q&A. He hasn't mentioned his name. He says that we all take chloroquine regularly, and he says he has taken HCQS now, and the incidence of COVID in the army is pretty low. That's the comment.
That's fantastic. But we would need a study, probably a retrospective data coming up, which will be really useful.
So 2 days ago, I was on CNN and there was a WHO and one from the infectious disease. And they were really talking about the chloroquine protection and malaria protection, which is seen in, and they were comparing between the countries where the malaria was not rampant versus. And it was quite an interesting discussion, which really says that there's something genomic is happening, which is why the infection rate is not as high in
Is it the gene of is it the
genomic
gene of the person or the
But
gene of the malaria?
people in these countries, because of malaria and chloroquine, the genome is slightly
Is it-
different. And yeah,
Mm.
so that was the
So
discussion.
malaria-
I think there may be one of the theory, and I think we will know in future. We may not know now.
Right?
Thank you, sir.
Yeah, I
Dr.
think-
Gagan, would you like to, Gagan and Pramod,
Thank
would you
you
like to thank everybody?
Thank you so much. Thank you. I thank everyone, particularly the chairpersons and the speakers. Dr. Nitin Sethi was up in the night. I think it's about 2 a.m. in New York. So he kept up the whole night to be here on the webinar. Dr. Rahul,
Thank
your
you very
talk
much.
And thank you both the chairpersons for really negotiating this webinar so well and making sure that all the questions were answered. And lastly, thank you, Dr. Pramod Pal, for having the words of wisdom and the wonderful advice and the direction provided. So we will certainly take this up and take up the webinar series in a big way, and keep watching the IN website and your email IDs, and we'll keep you posted regarding further webinars.
So there are a lot
Right.
of people
All the
asking
best.
for future webinars. So
Yes,
Gagan,
yes,
please kindly
we'll put
let
this
them
up at the website.
Thank you.
All the best. Good
Thank
afternoon.
you.
Stay
Thank
safe
you.
and stay healthy.
Thank you very much.
Thank you very much. Thanks everyone.
Thank you,
Bye-bye.
everyone.
Thank you.